Awesome. While we're waiting for everybody to join, let me just point out a few things about the Spiritual Care Network. Of course, our mission is to bridge the gap between mental health and faith. And the way we do that is we want to be resources to our faith community, to the churches. We also want to put education and spirituality back into the treatment process and offer education to mental health professionals as well as faith leaders. So we have some awesome speakers that we've been hosting in the last few months, and we have some scheduled the next few months. Kim, do you want to talk about some of the ones we have coming up?
Let's see. I know in the past we've just had Dr. James Boone from Hacienda Treatment Centers. What we have coming up, and you may have to help me, I know we have Dan Caldwell, who's an LCDC, LPC here in the Houston area. His CEU is going to be on ethics. Dan's got about 10 years experience in working in recovery. And I believe that's going to be December Eric, help me, 18th. It's the third Friday in December.
Yes.
Yes. In January, we have a person from Serenity Light, correct?
Yes. Christina, the clinical director, is going to be speaking. Oh, and it's a great topic. It's about the gender differences of addiction, how men and women react differently. And that's going to be fascinating. I'm looking forward to that.
Me too.
Yeah, you're different.
And yeah, and so that's for December and January, and then we do have some things lined up. I don't know if they're official for February and March, but we'll be able to announce that next time we're together. We'll do that maybe in our next December meeting. We'll kind of give an outline or forecast of everything we have. We're excited that we've been able to get that much, set up ahead of time, that there's people that interested in doing this. So that's awesome.
Yeah, and there's this really cool chick named Jamie. She's going to host our next networking. There she is. There's Jamie.
Hi, guys. Yes, thanks, Eric.
Good segue. Jamie at Life Giving Life is going to host our next networking meeting in the Conroe area on December 9th. Did I get that date right?
Yes.
And so that's going to be a special holiday networking where you can bring raffle items and all your materials, and we're going to all get together. Yeah, it's going to be fun. So great. Well, my name's Eric Ayles. I work at Starlite Recovery Center in Center Point, Texas. We boast that we're the oldest addiction treatment center in Texas, over 60 years old. And one of the things I'm proud of is that we do have a very solid Christian track called The Journey. And we have a beautiful chapel on campus. We have a chaplain that comes and worship on the weekends, and even studies from the Recovery Bible. So more at starlightrecovery.com. I'm also the board president for the Spiritual Care Network, and we are a network of mental health professionals around Texas. You could find more information at our website at spiritualcarenet.org, and I'll put the chat box in a few minutes. Our goal is to bridge the gap between mental health and faith, and it's just been a real blessing, even with the quarantine and COVID and not being able to meet in person. We brought the whole state together for these webinars, and so it's been a blessing, and we have some really good ones coming up. So if you'd like to join, there's information on our website on how to join and be an affiliate of the Spiritual Care Network. We look forward to that support. So let me turn it over to you, Kim.
Hi, everybody. My name is Kim Livesay. I'm an LCDC. I also do business development for La Hacienda Treatment Centers. Represent the North Houston area. La Hacienda has been around since '72. We're almost as old as Starlight. So we're on the Guadalupe River in Hunt, Texas. We're a 105-bed facility, inpatient treatment for substance use disorder. We do have several tracks. Some of them, we have the Christian track. We also have a collegiate track. We have professionals track. We have LGBTQ focus groups. Yeah, I think a lot of us are familiar with La Hacienda. so I'm not going to go into too much. I also own a women's sober living home here in the Woodlands, Texas, called Legacy House. My position with Spiritual Care Network is the chair for professional speakers. And so if any of you guys would like an opportunity to host some of our webinars in the future, do reach out to me. I'm going to include my email. And I am excited to introduce you guys. I'm going to probably let him do most of his introduction because he can do a much better job of it. But we're excited to have Dr. Michael Sprintz with us today. Sprintz is founder and CEO of the Sprintz Center for Pain and the Sprintz Center for Recovery, IOP, in the Woodlands, Texas. I've known Dr. Sprintz for pretty well for nearly the last year. We met during probably the beginning of this pandemic. I met him through John O'Shea, who's also a part of what we're doing today. John O'Shea, good friend of mine, very dear friend of mine, has a lot of history working in recovery in Louisiana and is here in Texas now. He is the behavioral health director for the Sprintz Center. And we are really excited about the topic, and I am just going to pass the torch to you, Dr. Sprintz.
Awesome. Thanks very much, Kim. And thank you guys, and thank you for the Spiritual Network for having me here. I'm definitely grateful to be here and appreciate it. I will start with my introduction, just a little bit about myself once we get started. So the first thing, though, is I always kind of start with letting people know who I am. So I'm board certified in anesthesiology. I'm boarded in pain medicine. I'm also board certified in addiction medicine as well. And I've been in recovery myself for over 20 years. So I have a really deep understanding and knowledge of addiction as it relates both from the pain side as well as professional in terms of treating patients with both chronic pain and substance use disorders. So we have a clinic here in the Woodlands, Texas, the Sprintz Center for Pain, as well as the Sprintz Center for Recovery, which is our recovery IOP. And obviously, we are darn good with chronic pain and substance use disorders, but we manage substance use disorders entirely alone, with or without pain. I know that's one of the things that we have a big challenge with right now is an increasing number of patients with substance use disorders and pain. Which brings us to our talk today. So I'm going to try and share my screen here. Let's see. I think I've done enough Zoom meetings by now to get this right. Can everyone see? I see nobody nodding, so I'll take that as a yes. And all right, so have you seen my MRI? I need these meds for pain. So this is about real world help for treating addiction patients with chronic pain. And let's see how we do. So I do a lot of consulting work. I do consulting work both for pharmaceutical places, for technology companies. I am the owner, founder and CEO of Solarian. This will actually be here afterwards. So if people need to see that, they can. So lenses, biases, and privileges. So what I've learned is it's really important that that I let my audience know who I am, where I come from, and what my perspective is. And so, I'm a cis white male. I was born in Chicago. I grew up in a middle-class family, well-educated. I do well on a financial standpoint. And those are all privileges, and including, I was fortunate enough and smart enough to be able to go to medical school. And all of these privileges and biases and lenses and perspective impact how I view the world. In the same way, it impacts how other people view the world. And I've chosen to take these privileges that I have and to use them to the best of my ability. The bottom line is I should have died a long time ago as a result of my addiction, and I didn't. And I'm not going to waste this life. So here we are. All right, so objectives. Learn everything an addiction treatment provider needs to know about treating pain in substance use disorder patients in an hour. Okay, and actually less than an hour. Okay, so we're not going to do that, but we're going to try the best we can here. So what I'd like you to take away is to be able to identify knowledge gaps in managing addiction patients with chronic pain, describing describe challenges that you face when dealing with addiction patients who have pain. I want everyone to commit to embracing and or practicing at least one technique, concept, or even just a perspective that you learn here today by the end of the week. And then I want you to leave with a few real world, actually useful techniques, concepts, or perspectives, and then a meaningful interaction with an addiction patient with chronic pain with the conscious intent of helping them ease their own suffering. And that's really important. I know sometimes we can kind of just go through the day and it's like, it's another one, it's another one. But the more we stay present and stay focused, the more we connect. And the more we connect, that's where healing happens. Okay, so welcome to my first meme. Welcome back, Cotter. So I have absolutely dated myself right now. And this is really the foreshadowing of what we're all going to be dealing with here in the upcoming months. In fact, as most of you know in the addiction treatment world, it's already here. So everyone is looking to us to address the opioid and actually a substance abuse crisis. But you can't avoid the ever-increasing influx of pain patients into your addiction treatment and outpatient programs. So the reality is that right now, the news cycle is covered with the presidential election and transition and the, and obviously that coronavirus that is devastating our country. But there's going to be a point in time where the vaccine is done. Whoever is president is going to be president, and the news cycle needs something else. And right now, just like addiction waits out in the parking lot for us outside of our AA meetings, it's here already. And you all are seeing that. You're seeing the increase. There's an increase in substance abuse. There's an increase in overdoses. There's an increase in new cases of substance abuse problems that are all happening because of what's going on in the world. And we're at a time with incredible uncertainty, incredible amounts of fear. People have financial insecurity, and many people are looking to change the way that they feel to help cope with the overwhelming stressors that we're all facing both personally and as a society. So the other piece to remember though is not everyone with chronic pain has addictive disease. And not everyone with addictive disease has chronic pain. But your responsibility as an addiction treatment provider in 2020 and in 2021 is to educate yourself on the basics of pain diagnosis and treatment, learn about pain meds and what they do, and be courageous in setting boundaries and speaking up. The reality is that pain and addiction are converging. And I have this talk with pain doctors as well, that pain doctors need to understand addiction medicine and addiction treatment. Addiction providers need to understand the basics of pain as well, because if we don't, we're going to miss it. And a lot of lives are at stake here. So find your superpower. I know, yes, find your cliched superpower and then use it. We all have certain things that we connect with our patients. There's certain things that we have that we do that's amazing. Find that and use that. You don't have to know everything, but if you can learn just a little bit and then start applying it, it's amazing the things that you can accomplish and the people you can help. Okay, so you guys are halfway or at least 15 minutes into your lunch break right now. So before you fall asleep, I'm just gonna give you the cliff notes here. This is what you need to know. So then you can just, snooze for the rest of it or hang out for a bit. So here's the bottom line. There's no simple answer. It really does take a multidisciplinary village to care for patients with addiction and chronic pain. The reality is that most addiction doctors are just as uncomfortable as you are in managing pain in substance use patients. Help each other. This is an opportunity for all of us to learn and to get better at this and to support one another. So the other important thing is addiction and pain patients are much more similar than you realize. And that's a really key thing to remember. Most people that I have found, both in the addiction side, addiction providers are terrified of pain patients, pain providers are terrified of addiction patients. And the reality is they're really not that different when we get down to that core part of what we're treating. You have to, moving forward in the future in the addiction space, if you intend to continue working in this space, you must learn the basics of pain diagnosis, treatments, and pain meds. Even though you may be a therapist, or a psychologist and like, well, I don't prescribe anything. The reality is you must understand the basics of what your patients are taking and why, because that really does have an impact on how you are going to deliver care. Even if it's in group therapy, understanding what your patients are taking and how that is impacting them. And the other thing I really have to stress, and I stress it every talk about this, buprenorphine, while it is fabulous, it is not a complete pain management plan. Okay, yeah, there's more. All right, so not everyone complaining of pain is drug seeking, and not everyone isn't drug seeking. That's the biggest challenge. How do I know when they're drug seeking? How do I know when they're really hurting and they need help? And it's okay not to know. That's really, really important. There's a level of vulnerability that comes with, especially in the healthcare community, of being able to say, hey, I don't know, but I want to find out, or I don't know, and I need some help with this. That is magic. People in healthcare like to teach and like to help, but not if nobody asks. Be present with your patient. We live in a super fast-paced world. Nobody has time for their patients. We're, everyone's in and out in 10.7 minutes. But the reality is that in the moments that we have with our patients, even just moments of being present and listening to our patients, one, our patients will feel heard, and that's heard builds trust. And then with trust, that opens up hope, and that also opens up a rapport and the ability to have healing. Because without trust, you don't have healing. And practice healthy boundaries with your patients and with everyone else. So a wall without a door isn't a boundary, it's a wall. Whereas a gate is a boundary that we can choose when to let someone in and not let someone in. Shutting everything down, and I've seen that in the inpatient treatment centers where I've worked, where sometimes if I don't know how to, if I don't know how to deal with something, then I'm just not going to deal with it. We can't do that. But we have to learn how to practice having healthy boundaries and being able to express them. So the general feeling when a provider discovers on intake that their addiction patient has chronic pain. Now, see, this is a much better slide in person because I don't hear any chuckles, so I'll just laugh for myself here. And this is the way that most providers handle the pain issue, but that's going to change. So ASAM, American Society of Addiction Medicine, of which I am a proud member, had an updated definition of addiction last September. It's a treatable chronic medical disease involving complex interactions of the brain, genetics, environment, and life experiences. People with addiction use substances. I'm not telling you guys, you all, anything that you don't already know. They engage in behaviors, become compulsive, and continue despite harmful consequences. Here's the key. Prevention efforts and treatment approaches for addiction are generally successful as they are for other diseases, like asthma, like hypertension, like diabetes. The myth that addiction is impossible to treat, it's a myth. I'm living proof of this. And trust me, I did not want to get sober. So let's talk about pain. Pain isn't just an injury. Pain is an experience. Pain is one of the oldest survival tools that we have. Pleasure and pain. What does the body do? Survival and reproduction, goals of life. Well, if I'm dead, I can't survive. So what does pain do? Pain tells us something's wrong before it kills us. It's our, hey, don't die early warning system, okay? But it's not just physical. Now, pain is physical, but it's also psychological, emotional, energetic, spiritual, and existential. Has anyone ever had a broken heart? That hurts badly. The reality is that we have emotional pain, we have psychological pain. That is very real pain. All of these things impact our experience of pain, as well as what we tell ourselves about physical injury as well. So experiential pain is real too. And that's important because a lot of times people will say, oh, you think my pain's all up in my head. Well, yes and no. The reality is is that the mind and the body are not separate. So when the mind, we're a whole being, and when the mind and the body aren't separate, they impact one another. And so although there may be something that is psychological going on that's impacting how we experience pain, it's real and we need to address it and treat it. Pain is a unique experience. Actually, there are biogenetic factors, there are cultural factors, gender, and co-occurring medical and psychiatric conditions. All of these things impact how each of us experience pain. I'm not going to go into the entire biopsychosocial model, but the bottom line is that we are biological, we're psychological, we're social. All of these things impact how we are sick and how we stay well. So there's a lot of different kinds of pain. There's what we call nociceptive pain. I broke my arm. That's plain physical nociceptive pain. We have inflammatory pain. Has anyone had arthritis? Yeah, and especially when the weather changes. There's neuropathic pain, which I think we see a lot of patients in treatment centers with neuropathic pain, like diabetic neuropathy and nerve-related injuries. But then you also have non-inflammatory and non-neuropathic, meaning things like fibromyalgia, irritable bowel syndrome. And these often are physical manifestations of experiential pain. And remember, the body and the mind are not separate, which means the body will listen to the mind. And I don't know if anyone has ever read The Body Keeps the Score. It's an amazing book on PTSD and how trauma impacts the physical body and manifests in the physical body. Unfortunately, not as many people within the pain world had previously grasped that, but they are now, which is great. So here's the key: suffering. It's much less about pain than about suffering. And suffering is the affective or emotional response in the central nervous system, triggered by an experience of pain or other aversive events. The other aversive events can be fear, can be replaying a trauma from the past, can be catastrophizing. I don't know if anyone's ever had a patient who's catastrophized before. Okay, well, I have. So the suffering is really the key thing more than the pain. I've had patients who have had horrible injuries and they're like, yeah, this hurts a lot, but I'm going to make it through that, and they're very resilient. And I have other patients who have relatively minor physical problems, and they're like, my life is over and it's never going to end, and oh my God, and what am I going to do? And they are truly suffering. So what we do, especially in the addiction space, is help manage all of that. Suffering is what we tell ourselves about pain. So there's a lot of evidence in the medical literature that depression worsens pain and trauma worsens pain. And the interesting thing is that trauma, if early childhood trauma has been shown to have a higher incidence of both chronic pain and substance use disorders later on. So people who have early childhood traumas, physical, sexual, emotional, psychological traumas, all of those can increase the risks of depression, of chronic pain, and a substance use disorder. It doesn't always take just genetics. All right, that's great, Dr. Sprintz. So what the heck do I do when my patient comes to me and they're, it's the middle of the night, we're in the inpatient, and they're telling me they've got pain? What do I do? Nothing else works except for oxycodone, and only the white ones with the speckles, not the other ones, or there's diffuse pain, or I've got pain everywhere. And when you touch here on my left shoulder, my right knee starts to ache. And it's the important part about what I'm saying here is that that's experiential pain. The patient oftentimes is actually experiencing that. But if we don't have the knowledge of how to understand and handle a patient who's experiencing those things, they don't feel heard, and it gets worse because there's also other factors that go on that can worsen things. So there's this balance of how do I know what's what? I have no idea what's going on. Well, if you have no clue what's going on, ask for help. Very few people, unfortunately, right now have extensive training, both in chronic pain and in addiction. We're really at the start of this. And I'm really glad that all of you are here right now, because this tells me that you are committed and you're passionate about understanding this. So this is the time where we all ask for help. I'm still calling up all my friends about stuff when I have a patient that I'm not sure about, both on the pain side and the addiction side. There's no shame in asking for help. In fact, it's courageous because, again, lives are at stake. And if we don't ask, we don't know. So why are these patients so challenging? Meaning, okay, so what's our part in this? Yes, we have a part. So part of this is the social stigma, right? And people's personal experiences with pain. There's some people, or with addiction. Some people have had really positive experiences with people with addiction. Some people have been hurt really badly from someone, and that colors how they perceive patients with addiction. There are, at times, and let's be, my experience has been that there are times where patients are annoying, demanding, manipulative, frustrating. And gosh, I think my dad said the same things about me when I was a kid. But really, it's true and it's honest. And I say that because it's important that we own our own feelings, because if we don't own our own feelings, we're going to act them out. So finding someone who is safe that you can speak with about that and own it and then not act on it is always helpful. One of the bigger problems with, or what I believe is the biggest problem with managing chronic pain and addiction is lack of training. That's not anyone's fault, except it's just the way things were, and now we know better. And once we know better, we can do better, and that's why we're here. So the goal now is to start helping people get the training so that you become more comfortable. And it's interesting, I had a colleague of mine who had told me, a pain physician had said, "Oh man, dude, I would hate to have your patients." And I kind of looked at him and I'm like, we've got the same patients. I just manage them differently. And that's really, really important. So once you get comfortable with understanding pain, just as you got comfortable with understanding addiction, all of a sudden, it's actually really straightforward, and you can manage them really well, but you need to be trained in them. So the other part, we are healers and we want to help, right? So that's the unspoken codependency of healthcare workers in general. We all have some degree of it, but part of that means that we weren't taught how to have healthy confrontations with patients. We want to help, we want them to like us, we want them to get better, and we don't want to have those really challenging conversations. What I love about my family in the addiction treatment world is that we're pretty used to having those difficult conversations. And what I'm talking about now is, as you gain understanding with pain, you'll be able to apply those skills even when you have a patient saying, "Look at my MRI," and there's all this, metal and bones, and you're like, "Oh my God, I don't know." But you'll be okay. You'll be able to handle that in a healthy way. Okay, so what's the common core emotion that dominates both addiction and chronic pain patients? Fear. Everything meets at fear. Fear of relapse, fear of dying, fear I'm not going to get what I want, fear I'm going to lose what I already have, fear I'm never going to get out of here, my kids, my job, I'm going to go to jail, all these fears, or I'm never going to be able to quit. Pain patients have the same fears. Oh my God. And for the record, I herniated a disc in my low back, and it was the most painful thing I'd ever experienced. And that fear of, this is never going to go away. This is never going to go away. Oh my God, if I live like this, I can't live like this. And so the things we tell ourselves. So fear and suffering. All right. So that's great, Dr. Sprintz. What's our goal? Goals for treatment, pain, or addiction? They're similar. Reduce pain, reduce suffering. We want to improve function, quality of life, and we want to re-engage in life. We want to identify and address beliefs, especially the false ones, that keep us stuck. We want to learn skills for coping with life and with pain. and with sobriety. And we want to reduce reliance on meds, not just opioids, but reduce reliance on anything. Multimodal therapeutic interventions. If I can get a patient so they never have to see me again because they have managed their pain and they've maintained sobriety, and they come back once in a while to say, hi, I've done a great job. Go tell your friends. I don't need to keep more patients. We're never going to run out of addiction patients. We're never going to run out of chronic pain patients. So to assuage anyone's fears of not having enough patients, we're never running out, unfortunately. And then minimize risk for relapse. Now think about this as you're reading this. This applies to either pain or addiction. Do you see how it's all coming together? Once again, buprenorphine alone is not a complete pain management plan for addiction patients with pain. It's a great start. And I don't want you to think I'm down on buprenorphine. I do buprenorphine in my clinic. I have patients that I wean off with buprenorphine. I have patients that are appropriate that we maintain on buprenorphine. And I have pain patients that I use buprenorphine with who may or may not even have a substance use problem. It's a great drug, but you have to understand its place in the bigger picture of how we're managing things. It's a lazy provider that just slaps on some buprenorphine and in a chronic pain and addiction patient and doesn't do anything else. That's not doing justice to the patient. It's a whole thing. So successful management requires a multidisciplinary approach. It takes truly a village. So we want to treat the mind and the body. We want to treat the physical parts of the pain. We want to treat the emotional and psychological parts of the suffering, the things that keep us stuck in pain loops or depression or PTSD. We want to stay sober. So there are pharmaceutical therapies. There are psychological therapies, procedural interventions, physical modalities, as well as complementary and alternative therapies, Reiki, energy medicine, yoga, Pilates, physical therapy, mindfulness meditation, CBT, DBT, and on and on and on. We have a tremendous amount of therapies here, but we use them together, okay? So it's an integrative approach. The benefit of that is it provides structure, it provides structure, and it enables us to communicate with one another because these patients are complex. So pain evaluations should be ideally done by fellowship-trained pain medicine physicians. If you have a patient who has a pain complaint and it's challenging their ability to stay in treatment, send them to a pain doctor who can do a good evaluation on them or an appropriate one. Fellowship-trained pain medicine physician, not just someone who says they do pain, okay? Clarifying that. If you guys are in the Texas area, in the Woodlands area, we are happy to do it. All three of the physicians here at Sprintz Center, we're all boarded in both pain medicine and fellowship trained, and we're all boarded in addiction medicine as well. So we do get it. So how to discuss pain with your addiction patient? Number one, have a plan, okay? You wanna have a plan because as you walk into that room, you wanna have an idea of what their pain is, what's causing it, where's it going, what's their challenge right now. And if you're not sure in the middle of that interaction, you can pause and say, I'll be right back. I need to talk with someone about this so we can help you. Be present and hold space and listen. It is amazing the healing factor of just being able to actually be present with them, even if you may not be able to eliminate their pain. Do their complaints make sense? Does the pain, doc, I got a pain in my low back that shoots down my butt, wraps around my knee and goes into my big toe. Oh, okay, well, having a basic knowledge of pain anatomy goes, okay, that makes sense. Versus, well, doc, when I touch my shoulder, my left shoulder, my right knee hurts, and you got to fix it now. Well, that's something else is going on there. So this is where your basic knowledge of pain helps. Be non-judgmental. As addicts, we've all, I speak for myself, I have felt stigmatized, I have felt judged. And these days I've got no shame about my past, and it's a wonderful place to be. Not everyone is there, unfortunately. And, but the thing is I see this in chronic pain patients too, who have no addiction background at all. They've got no history of addiction. They don't have addiction. And yet they go to the pharmacy and everyone looks at them like they're an addict. And being non-judgmental, walking in, hey, look, you know, when a patient comes in, hey, yeah, I shoot heroin in my eyeballs. Okay, left or right? Because at the end, it doesn't matter what they do. It matters, how can I help you? Because they're in front of us in that moment. And when they don't feel judged, that opens up that rapport and trust. And then deal with the facts. Hey, Johnny, I know you say that there's no way that meth could have showed up in your urine, but it's here and we have to address it because it's here. I got to deal with that. You're not calling them a liar. You're just saying, here are what the facts are and I got to address it. Recognize manipulation. This takes time. I've been burned. I know everyone here on this call has been burned at some point or another. Whenever we have, I've taken an opportunity to learn from it as best as I can. We get better at it, but not everyone is manipulating. Sometimes people are hurting. And that's something that I found in the inpatient pain space, where we got used to breaking down the wall of denial. Well, sometimes that invalidates someone who's truly suffering from pain if we just go, no, you're just drug seeking. So take a moment or two to really ask yourself those questions. Those pauses really help. Don't negotiate with terrorists. You know, you're going to make me go out and relapse. You're going to make me, if you don't treat my pain right now with Dilaudid, I'm going to go out and buy methadone on the street. Okay, but I'm not making them. And I don't negotiate with terrorists. Oh, but they're going to go out on the street. No, here are the options that we have. It's just that methadone isn't one of them. Set firm, clear boundaries, like I just did, Exhibit A. And then keep those boundaries. And then the last one, if you haven't detected some theme here, ask for help. If you're not sure how to manage a patient or what to do, or they're coming up with something that you're stumped on, ask for help. There's a lot of, and here's another part for you to take away. Pain management is not just pain pills. And when I say pain pills, most people think opioids. I spent a year of my life after 4 years of, or 3 years of anesthesia and an internship to do a pain fellowship to realize I knew nothing about pain until I really got into it. So there's a lot of different ways we manage pain, and that all depends on what kind of pain it is. So we have interventional procedures like injections and spinal cord stimulation. There's physical therapy. There are psychological therapies, and all of these, and meditation and energy work and spiritual practices. And all of these things can help impact our perception of pain, because pain is an experience. So if spiritual practices and mindfulness and meditation change how we perceive ourselves and change our suffering, that helps with pain. So benefits of interventional pain management. These are the procedures. So everyone's heard of an epidural steroid injection. I'm going to wing through this because we are running out of time. Spinal cord stimulation. You are going to be seeing a lot more of this in your practice as more and more pain patients, as more and more pain patients end up in addiction treatment, or as more addiction treatment patients start really complaining of pain after numbers of surgeries. Spinal cord stimulation uses electricity to interrupt the pain signals to the brain. The beautiful thing is it's not drugs, it's electricity, and it interrupts the pain signal. There's a lot of stuff on the horizon now with regenerative medicine and stem cell therapy. It's for the first time we're starting to have something that we can do that actually can reverse the damage done by arthritis. So in our elderly patients with the really bad knees, we now, and we do this in our clinic as well, is that we're able to give these things, and regenerative medicine, again, it's not drugs, but it treats pain. So it can play a role. And I know most of you are familiar with the SSRIs, the antidepressants, and the tricyclics and the NSAIDs, but it's really important that you know there's a lot more out there, and you really need to educate yourselves on them so you understand why someone's on those things. If they're opioids, and I know in some states they're talking about cannabinoids, you really want to refer to a pain and addiction specialist for an evaluation. But the reason why you also need to know pain is because you are going to be sent a lot of patients from pain doctors saying, is this patient appropriate for opioids? And if you don't understand at least the basics of pain, you're not going to be able to actually give them an accurate answer, right? But if you do know pain, you are going to be incredibly sought after and you will never be for lacking of a job. I'm telling you that now. Physical therapy, improve strength, balance. I want to get to the other stuff that's really important. Pain management and sobriety are possible. You have to treat both, but you can have good pain control, great quality of life, and sobriety. Just because my doctor prescribed it doesn't mean I have to relapse. And just because someone has addictive disease does not mean they have to suffer. What it means is we have to manage them and help them with both their addiction and their pain in a safe way that enables them to get appropriate pain control, not necessarily the way they might prefer the first time they walk in the door, but it enables them to have that quality of life. And I think for most of you who have seen a patient who's actually done well in sobriety and then have gone on and progressed to have good pain management, it changes lives. And I had a patient from beginning of my practice that was that actually had said, when I first saw her, the phone call I first got was, look, you don't want this patient. Literally, they said, you don't want this patient. And I'm like, oh yeah, just send her over. Well, this patient was on, had been on all different kinds of medicine for 14 years, wheeled in a wheelchair by her elderly parents, couldn't hold a coffee cup, slurring everywhere, she had a spinal cord stimulator that wasn't even working. She had a implantable pump. She was on 2 long-acting opioids. She was on a short-acting opioid. She was on a benzo. She was literally like an entire pharmacy. Of course, she couldn't hold a coffee cup or talk. And I looked at her and her parents and I said, I've got no idea what you have. I don't know. But we need to get you off of all of this to figure out exactly what's going on. So now, fast forward, I've now been in practice. That was my first 6 months in my practice back in 2014. Now we're talking 6 years later. This person, she got sober. She's not on any opioids or any mood or mind altering medications. She went back to school, became a counselor, working on her master's. There are amazing stories of recovery, both in pain and in addiction. She's a rock star. But if we didn't give them that, if she didn't have that opportunity, who knows what would have happened? She, like many patients out there, they just stay drugged and they die. And so our ability to say, hey, look, we can figure this out together. And that was a team effort, by the way. That was not just me, that was everybody. So what's the long-term plan? So I think a lot of people in the audience are working in treatment centers where you'll have residential and or IOP, and then now what? Or if it's just detox, well, what do we do with our patients once they leave when they've got chronic pain? Chronic pain is chronic. And unfortunately, as far as I know, actually the Sprintz Center for Recovery up here in the Woodlands, we are the only place that are true experts in chronic pain, in managing chronic pain and substance use disorders as an IOP in an outpatient setting. Remember that pain is a trigger for relapse, or should I say untreated or undertreated pain can be a trigger for relapse. Additionally, patients have appropriate legitimate surgeries. How do we prevent relapse in a patient who's about to have surgery? These are the things that we have to think about when you're doing aftercare planning. So making sure that you're connecting and talking with, know thy patient, connecting with and talking with pain providers that understand addiction in your community is really vital to help keep your patients sober. Being able to address pain in your IOP, at least at a very minimum, holding people accountable. Just because a doctor prescribed medication doesn't necessarily mean the patient's not in active disease. because a patient can present with a certain set of symptoms to get exactly what they want if the physician is unknowledgeable about what they're dealing with. And for the record, I have this talk with pain docs and with addiction docs all the time too. And my hope is that as we all become more educated, we'll start to see that, and we can help people not relapse, not hurt themselves, and have this amazing, incredible life. Everything I'm doing now and the life I have now, which is I'm incredibly grateful for and amazing, is because of recovery. It's because people like you were here when I had no idea what this all was and what to do. And so I want to say thank you, and also know that you're helping more people than you realize. So here's what you need to know. Learn the basics of pain diagnosis, treatment, and pain meds. Uh-oh, I'm seeing the gong here. Understand what non-opioid treatments options are available, meaning learn about what a pain doctor really does, not just what you see on the news. We really are not all bad, I swear. Communicate with pain docs and ask for help. They need your help to teach them about addiction medicine. You need their help to teach you about pain. It's a win-win. Most addiction doctors are just as uncomfortable as you are in managing pain. Help each other. This is where, throughout the hierarchies, guys, we're all here together trying to do the very best we can for our patients and ourselves. Fear is the core emotional driver of pain and addiction patients. Did I mention fear is the core emotional driver of pain and addiction patients? This is where we all converge. So the skills that you have learned over all these years in helping and managing addiction patients, you can apply those to chronic pain patients because they're struggling and suffering from the same issues emotionally. You've already heard me rant about buprenorphine, which I love in context. So like I said, not everyone complaining of pain is drug seeking, but some are. And the more you learn, the more you'll be able to help them. It's okay not to know. Be present with your patient and listen to them. Being heard has incredible therapeutic value. Healthy communication and boundaries is really vital with our patients, with our colleagues, with our family, with everyone. I'm involved in CODA and Codependence Anonymous, and that was one of the greatest gifts I ever learned through CODA was what healthy communication, what healthy boundaries are. It changes everything for the better. And the long-term care plan with experienced pain and addiction specialists to prevent relapse after discharge. Effectively addressing pain management, pain and addiction is complex, and don't give up. Truly, you may be the only shining light your patient sees. Thank you very, very much. I appreciate being here. And how'd we do on time?
Perfect. I think we did really well.
I would like everyone to hear my timer for a moment.
Wait for it. Wait for it.
Wait for it. Hold on, hold on, hold on. This is kind of fun here.
Yeah.
Okay.
Thank you.
Oh, that's awesome. Thanks, Dr. Sprintz. That was incredibly informative. I can say I actually learned a few things today. I got a lot to learn though. I do have some questions.
Sure.
I would welcome more from you guys that are tuning in right now, but here's one of our first ones is-
Kim, I'm also happy to stay on longer if people have questions. So if that's helpful, I'm more than happy to.
Okay, thank you. We have a question from Diana Dean. Buprenorphine, what is it?
Excellent question. So buprenorphine is in the family of opioids, but it's what we call a partial agonist antagonist. So it hits the same receptor that hydrocodone, oxycodone hit, but it binds tighter to that receptor, but doesn't activate it as much. So that's a whole lecture in and of itself. So the benefit of buprenorphine, I want to be clear, it is an opioid. It can be abused. It is absolutely diverted. It's one of the most diverted drugs because it completes the cycle of trying to quit and buying it on the street, and then the attempts to control. Buprenorphine is a street drug that people do that. So it's not benign. Okay, I want to be clear about that, but it's also incredibly helpful for MAT, for helping people stay in treatment. The benefits of buprenorphine, it has a lower overdose risk, so it decreases respiratory depression. So it's safer, right? So it's safer from an overdose perspective. And because of the way it has these very unique properties that make it good, a really good tool to help people prevent withdrawal, but not get really high.
Okay.
That's a good point. Can you talk a little more about MAT and your thoughts on that?
Okay, yeah, well, I can talk for a while on that. So I grew up in the abstinence-based model. Buprenorphine wasn't around when I first got sober. Oh yeah, October 15th of 2000 is my sobriety date. So I just
Wow,
years.
that's awesome.
And I have a sponsor and I have sponsees and I do really love recovery. So I had a hard time with MAT because at first I was like, well, wait a minute, this doesn't make sense. And I did it without buprenorphine. And what I learned over time is that the reality is that this problem is a public health disaster. It's everywhere. And when I got honest with myself about when we talk about privileges, what was available to me to get sober, I wasn't married. I didn't have any children. I didn't have a job that was going to fire me if I took time off. I had disability insurance. I stayed in treatment for a year, almost a year and a half, and I needed every moment of that. I wasn't a minor addict. I definitely earned my seat here. But most people don't have that opportunity. If they don't go to work, they lose their job, or they'll lose their house, or they don't have insurance, and they can't spend a year in treatment. So there's a huge public health benefit to MAT, which is not just buprenorphine. MAT can also be naltrexone, and naltrexone decreases cravings, but it does not have any euphoria. So we do naltrexone as well as MAT. At the end of the day, I look at it like this. When I treat it like diabetes or high blood pressure. When I have a patient who comes in with diabetes on insulin, I want to get them off of insulin. That's the goal. Let's get you off of insulin, and we're going to teach you about diet and exercise, et cetera. So, it's the same thing with MAT and Bupe. The goal is always to get people not to need any medications so they can be emotionally sober. And when those emotions hit, they're fine, and get them through the withdrawal period. Okay, that's the other benefit of Bupe is withdrawal. But MAT is vital right now, and in helping keep people in treatment, because if they don't stay in treatment, they go out and they overdose and they die. And you can't get someone sober who's dead.
Right.
You can't. So there's a huge role for it. And I don't believe that it is contradictory to an abstinence-based model. I think everyone wants to get there, but sometimes people aren't there yet, so they need help.
Sure.
I'm a big fan of putting it all together.
Perfect. Thank you. That's awesome. What are some common non-medication therapies that you like to use for pain?
So physical therapy is a great tool. When we move more, we hurt less. Where we think, oh, I'm hurting, I shouldn't move. But when we stop moving, we get stiff, and then we hurt more. So we move less, so we hurt more. So doing physical therapy, yoga is fantastic. Things to keep us limber, flexible, active is always good. We do procedural interventions that, like, for instance, I was talking about the spinal cord stimulator and regenerative medicine, like stem cell therapy. They're not psychoactive. Well, I mean, electricity for the stimulator is electricity, but stem cells are not psychoactive, meaning that they don't impact our perception in the central nervous system, but they decrease inflammation and they actually enable healing of joints. That's fantastic. Some insurances pay for it. We have now one that Medicare covers. Some of it is cash only, but it's moving in that direction.
Okay.
So, and then obviously therapy, hypnosis, hypnotherapy, CBT, DBT, all of the psychological therapies and counseling are vitally important, because if we don't change beliefs, if we don't change what we're telling ourselves about pain, then we're going to stay stuck. So it's really about treating our psychological and emotional parts as well as the physical parts.
Got it. Something that's gotten a lot of attention around here lately, Woodlands area, and I can't speak on behalf of it, is the microcurrent neurofeedback in regards to pain. I know that BioSound feedback is getting a lot of attention too. We just had a recent webinar on that. I'm not sure that that addresses pain as much as anxiety, but that's just kind of new and interesting to me. I think it's been around a lot for a while. You probably know, maybe just called something else, or do you have any thoughts on that?
Yeah, I mean, I do. I have some experience with neurofeedback, and there's a number of different technologies that are coming out that are being tried and utilized in pain, and I think that they definitely have merit. We need. It's one of the tools in the armamentarium. And you mentioned something about, well, that treats anxiety, not pain, but anxiety worsens pain. Mm-hmm. So if we can help manage anxiety with tools like neurofeedback and biofeedback and these other technologies and tools, by decreasing anxiety, we decrease the catastrophizing effect and therefore improve people's pain experience. So they are related and they can help. I think it takes I'm challenging everyone to take this leap about how they view what the term pain means. It really is a much broader experience rather than the physical, I'm injured.
Sure, I get it. So one question was, let's see, it's by Stephen Flores, and he says, who do you recommend in San Antonio to partner with, or should I move to the Woodlands, LOL?
Oh, move to the Woodlands, duh.
Come on, bring it.
Yeah.
Do you have any practices anywhere near there, or do you want to think about that and kind of get back to him?
Email me. I can share my screen here for a minute with my.
Yeah.
Yeah. So yeah, feel free to email me. I don't have someone off the top of my head. I have someone in Dallas that I know. There may be some other people. And also for anyone in the audience, if you know a great pain doctor who understands addiction, first of all, if they're anywhere near you, grab onto them and don't let go, because we're rare creatures. Hard
to find, I can assure you. Very.
Yeah. Sure.
And then also one that happens to be in recovery. That is like a unicorn right there. So
I've got the horn and everything.
Absolutely.
Actually, I have a question.
Yeah, Jamie has a question.
Okay.
So working with a lot of families and people that do have issues with chronic pain and substance use disorder, can you kind of give some red flags on when like a parent is researching for pain management, or like a client is wanting to find a good medical?
Absolutely. The first thing you want to look for is for someone in recovery who wants to stay in recovery, the first thing you want to look for is you want to make sure that they are fellowship trained, meaning they did a specific year specializing in pain management. It's not someone who's a family practitioner who does pain. Okay. So you want someone who's fellowship trained and board certified. Absolutely. If they're not, they're never going to get what we're dealing with here. So that's the first cut. The next cut is actually, especially if you're in recovery, is when you talk to the doctor and you say, hey, look, I'm in recovery. If they tell you, well, only use what you need, run.
Mm-hmm.
Okay. You want someone who actually understands it's the first one that kills me, not the last one. And just because a doctor prescribed me an opioid or a benzo, right? Because get ready, psychiatrists, because eventually it's the benzos as well. And they're very hard to stop. But the problem is for addicts, we're like, well, the doctor prescribed it, so I'm taking it. And the doctor may not know. He may not be a bad doctor, just doesn't know. And the patient, trusting the doctor, may not know. So if something doesn't feel right, if your recovery radar is like, wait a minute, he just wrote me the script. Generally speaking, the goal is, I don't want anything. I don't want opioids. That's your first basic one. If there's a way to avoid it. Now, I can give a whole talk on when it is appropriate for people in recovery, but that's not within the scope of what we're talking about right now. But when you're looking for a doc, if you're, you know how you can go to, in AA, you can go to the rooms, close your eyes, and you can hear who has a sponsor? Kind of a similar thing. If the doctor doesn't have credentials, or the doctor's like, yeah, no, it's fine, I got it, yeah, that's good. I would be concerned, at least, and look at their reviews, talk to people. Absolutely. This is the most important, your life depends on this.
Yeah.
It's worth drive, you know, a doctor, a hairstylist, and an auto mechanic drive wherever you need to go to keep a good one.
That's right.
Amen. Amen. Well, what we're going to do, I'm going to pass it to Eric, but don't go anywhere, Dr. Sprintz, because we do have, I'm looking at least a couple more questions. So we can kind of wrap it up with Eric and then stay on for the additional questions.
Sure, happy to.
Okay,
All right.
great.
Just a few other things. In just a minute, you're going to get a link to do the evaluation and print off your certificate of completion. So if you need the CEU credit, please do that. We're also going to send an email tomorrow with the same information. So if you don't make it today, you'll be able to do the evaluation tomorrow. Stay tuned. If you're not on our email list to get the updated information from the next meetings and webinars and all the exciting things that we're doing, you could go to our website and sign up to be on our email list. Once again, that website is spiritualcarenet.org. And huge thanks for Dr. Sprintz for speaking today and sharing your wisdom and educating us. That was very good.
Absolutely. I'm glad. Thank you for letting me be here. And I appreciate everyone who showed up and stayed.
Awesome. And thank you, Kim and Jamie, for being our co-host today and helping this go smooth. It went really well today. I do want to have some more time, but let's go ahead and just kind of end it for those people that need to jump off. And let's end with a word of prayer, if you don't mind. So let's bow our heads. Dear Heavenly Father, just thank you so much for bringing us together and learning and sharing with each other. And I just want to pray for all the professionals on this webinar and even in the field and all the members of the Spiritual Care Network. Give us wisdom and help us as we help other people that are struggling with physical pain, mental pain, spiritual pain, and give us the right things to say, give us the knowledge so that we are just a tool for you. And we are just so thankful for all our gifts that you bring us in this season of Thanksgiving. In Jesus' name we pray. Amen.
All right. Amen. Thank you, Eric. Yeah, and thank you so much, Dr. Sprintz. This was amazing. Yeah, you've had an incredible response is what I'm looking at as far as people and questions. So I know we could do this literally all day. In fact, I could sit and ask questions all day, but I'm gonna go with our friend Julie Eisen with the Right Step. She's asking, she said, great talk. What are you seeing during COVID as far as relapses or increase in depression?
It's an absolute disaster. It is going to be a tidal wave that's already started.
Yep.
Yeah, it's already started. I had said it a long time ago. It's the perfect storm. You've got social isolation. You've got economic uncertainty. You have political uncertainty. There's fear. There's financial uncertainty. Everyone's losing jobs and people are stuck at home. So domestic violence has skyrocketed. And when we feel fear, we attempt to control our environment or our people or change that fear to feel safe. It's a natural urge. Well, a lot of people are now turning towards alcohol and other substances, and it's rising all over the place, and it's going to continue to get a lot worse. And I'm trying to raise as much awareness as I can about that. So thank you very much, Julie, for bringing that up. It is a very real problem that people haven't started talking about yet.
Thank you. Yes, agreed. We're all seeing, all of us that do this, the numbers rising like never before. And then the treatment centers are obviously several, I speak on behalf of mine, we get a little backed up because we can't take in as many as we could before due to having to the detox and not being able to kind of have, you know, more than one person in a detox room at a time.
We do have
So-
space at Sprint Center IOP if necessary.
Yes, I was going to say, tell us just a little bit real quick, and then I have one more question about what you guys do there at your IOP. What does that consist of?
Well, it's we have the aspects of a traditional IOP, which is 3 to 4 days of both group therapy and individual therapy, but it also occurs at our practice. So, you know, as we're all subject matter experts in chronic pain and addiction. So, you know, especially when people are you know, coming from another program or having chronic pain complaints that they need to be managed, we actually can do all that you can in a traditional IOP, but we're also able to manage pain confidently and effectively actually in the same place. So we even have a procedure room in our IOP. We're able to do procedures there, and we're able to manage pain as well as managing the substance use part. So we have groups. Yeah, I mean, we're really, there's not much we can't handle when it comes to chronic pain and addiction. And if we can't, I ask for help.
That's really unique, you know, and good to know. Very
Yeah,
unique.
when I first started, I was the only private practice pain and addiction outpatient center outside of universities this side of the Mississippi back in 2013. They had larger universities, but not private practices. So I've been doing this a while, and I've seen some interesting stuff, and it's really evolved. I mean, even my own perceptions have grown and changed over the years, and it's really been an incredible experience.
Right. Yes, and I so appreciate your perspective.
Yeah. And John, by the way, John who runs our IOP, John O'Shea, is fantastic.
Yes.
And I know actually I met Kim through John. He's really he's made a huge difference here at the Sprint Center, and so we're really, really grateful and blessed to have him. He's fantastic.
He is. He is a great guy. So glad to have him here in Texas with us. Jamie has one question that we're going to read off, and then we'll see if we get any more.
What is the difference between acute and chronic pain?
Well, there's two basic definitions of acute and chronic pain. So one way of looking at it is some say acute pain is something that is immediate, meaning post-surgical pain, or you have an injury that gradually heals. And then the pain goes away. So if you've ever sprained your ankle, a couple weeks later, you can barely walk that day, but then the pain goes away, your ankle heals, and you move on. But chronic pain is something that lasts, either it's defined as lasting greater than 3 to 6 months in duration, or it's pain that continues to last past what is normally or physiologically expected pain to last. So there's something, called complex regional pain syndrome, which is just a weird dysfunction of our nervous system, where let's say you have an injury to a nerve that should heal, but instead it gets worse and worse and worse and worse over time, and then it becomes chronic.
Okay, thank you. I have one question myself, and trying to figure out how to word it exactly right. So I take part in part of a sober living home, and there's a lot of controversy and confusion and different schools of thought on how to treat the medicated assisted treatment person in the same home with the abstinence-based person. And that's going to continue to be tough. And I think the answer is obvious, and it's to have maybe abstinence-based homes, medicated assisted treatment homes, or just, I don't know, I don't know the exact answer, but the question, and hopefully that happens. We need more, especially.
We need more of everything.
Oh yeah. But when would you, so you've got a patient in front of you that is an opiate addict, and you've got some choices, or as a doctor on what you're going to prescribe, what would have you go towards the buprenorphine or the Suboxone route, or the naltrexone / Vivitrol route? What helps you determine that, which is best for them?
So it depends on a number of factors. So first of all is what kind of pain that they have. Or are we talking about patients with just substance use disorder, not worrying about pain?
I'm assuming you're going to be seeing them with a little bit of both typically, right? Or often both, or
Yeah, I mean, I can answer both, but it's, again, so
let's go with
first
substance
question
use disorder. Let's just say there's not a lot of pain there. Maybe it's phantom pain, fake pain. You're really, you've cued in on them that you feel like this is probably substance use disorder primary.
Okay. Well, and to be clear, phantom pain actually is a real pain syndrome.
Okay.
But the thing is that, so the first thing is someone who presents with pain, but it's not really pain, it's a substance use disorder. Okay. So in that scenario, the first thing that I would do is, one, that gives me, my first clue is that they're not being honest with me. So where are they in the motivation to change? Right now, if you're lying to me, telling me you've got pain and you're trying to get medications, you're a less likely a great candidate for MAT, or for buprenorphine, although you still may be, because the other factors that I have to think about is, at the end of the day, what's best for the patient, and do the benefits outweigh the risk? And then the last thing is, when I think about clinical decisions that I'm making, is what's best for the patient and what will I say on the stand? Because generally speaking, if I do what's best for the patient, I can sit on any stand and say exactly what I did because it was best for the patient after weighing the risks and the benefits of whatever that clinical decision is. So depending on that patient, what I look at is, where are they in terms of acceptance of having addictive disease? What's their social support structure, right? I mean, do they have, the number one factor that we're finding is, in terms of what is the number one factor that causes people to relapse in treatment? And it's in IOP or something, it's having a spouse or a partner at home who's using. And I mean, I know, duh, that makes sense, but it's all of these factors versus I've had some patients who recognize they've got a problem and they're done and they have a supportive home, but they still need to go to work. They can't do inpatient. Being an outpatient provider, I get a lot of patients who are like, heck no, I can't do inpatient. So, and we don't do inpatient at all, which is why I love all of you, because I have places to refer. But a lot of times they're like, I can't do it. I've got to go to work. I'm a single dad or a single mom. And so then I look at, okay, where are they? How honest are they? What other issues do they have going on? What comorbid psychiatric conditions do they have that are going to impact that? What's their home situation like? Is there a history of trauma and PTSD? Is it treated or is it untreated? Where are they in terms of, social, economic support, family support? What are their other challenges, whether it's legal, whether it's domestic? Because as we know, when I was in my active addiction, I screwed things up really badly, and lost a whole bunch. And a lot of people have really challenging home lives and really challenging situations the moment they're coming into treatment. Right. So all of those things are, and at the end of the day, if I prescribe buprenorphine versus now, I would prefer to do naltrexone. It's less risk for me, it's less risk for them, and I mean that's wonderful and great. But the reality is a lot of people are not willing to do that. And is it better to? I won't draw a firm boundary because sometimes it takes a little bit for someone to just be around long enough to start to get it. Yeah. I was one of them. I was a slow learner. It took me like 6 months before I was like, oh, I feel better about myself. But, so having a hard and fast rule and being rigidity is part of the problem. Oh, I will only do this, and because I'll have patients, I often don't label patients. Well, they'll be like, doc, do you think I'm an addict? Now, every once in a while, I'll be like, yeah, welcome to the club. Hi, I'm Michael, addict, nice to meet you. But for a lot of people, they'll ask me that, do you think I'm an addict? I don't know. I've met you for 20 minutes. You have things, I'm concerned. But whether you're an addict or not an addict doesn't matter. What matters is that you're here and something's not working. Because if I label them an addict and they're not ready, boom, all the rapport is gone.
Right.
They won't trust me. Who's calling me an addict? I'm not an addict. Whereas if I'm like, I don't know, because the reality is I already know how I'm going to manage that patient. Why do I need to shove it down his or her throat where I can go, look, what you're doing isn't working. Let's try this. And I want to bring up one thing that you almost mentioned but didn't, that I think is important.
Sure.
Buprenorphine, that intermixed of buprenorphine and abstinence in the same household.
Yes.
Or in the same treatment facility.
Right.
The challenge isn't whether or not someone's on it or not. I mean, so you have to answer the question, why does Billy get to be on buprenorphine and I don't, right? We're emotionally about 7 or 8, and that's not, that's a fair question, right?
Yeah.
And so the best answer for that is, in Billy's situation, for a number of reasons, it is the most appropriate therapy for Billy. It is not the appropriate therapy for you. I cannot talk to you about Billy, but I can sure talk to you about you. And the goal for both of you is that at some point, neither one of you are going to need any of this. Okay. So that's the ideal conversation, which we all know rarely goes that smoothly.
Right.
Let's call it for what it is.
Right.
The bigger problem that you have with abstinence-based and a non-abstinence-based in the same place is you've got the diversion problem. Diversion problem, because someone's going to cheek it and give it to someone else.
Thank you for saying that.
It's what we do.
That's the reality of what really happens, and so, I mean, not always, but it can sometimes be the threat.
It's part of the risks.
Yes, it is a risk.
Right. And so again, a hard and fast rule one way or the other, it's not my place to tell any other treatment program how to run their program. Everyone has different philosophies, and I know there's a lot of conflicting views. It's a challenge. There's not a simple answer for that, and no one's wrong and no one's completely right. We're all in there trying to figure it out right now. And ultimately, we're going to find some of the better solutions. But, one of the nice things sometimes that you can think about are they now have depot formulations of buprenorphine. So long-acting sustained release formulations, that's a shot that lasts for a month. We're off the CME thing. So I'm working with a nanotech company that I actually did, when I couldn't go back to anesthesia or go back to medicine, I actually did research in nanotech, and we worked on an implantable drug delivery system. They're actually working on something now with to be able to deliver medications like this. And
that's
so
awesome.
for 7 months, the beauty of these medications, or the beauty of these delivery mechanisms, are that you're not dealing with strips. So the diversion factor goes down. So all of a sudden, would your view change if you had a sober living house that one person had a depot injection so no one else could get it?
Yes.
And someone was abstinence-based? Would that make
a very big difference?
I agree.
I can assure you. So maybe in touch with you about that. Okay.
Absolutely.
Hey, I think we actually ran out of questions, but
Ro Reynolds raised his hand. I don't know if Ro is still there.
Let's see. Are y'all able to get to the hand raisers?
Ro just raised his hand. Did we skip you? I apologize.
I can't see that part. Maybe Eric can.
Oh, my bad. I'm completely sorry. Wait, there's one question. Oh, do I have a lot of luck with treating fibromyalgia patients? Is this a diagnosis that doctors may throw at a patient because they can't figure anything else? So to answer your question, we do have success with treating fibromyalgia patients. The first thing is a correct diagnosis. So yeah, we do. Oftentimes, but your second question, is this a diagnosis that doctors throw at a patient because they can't figure out anything else? Unfortunately, that happens also. Fibromyalgia is challenging. They have found some genetic markers in tissue biopsies that confirmed people used to believe that fibromyalgia was a totally made up disorder. It's not a made up disorder, but a lot of people in the pain world may treat a patient like that. And that's where we get back to stigma and judgment, and because there's not this clearly defined herniated disc pressing on a nerve. So therefore, the patient's faking it. You know, they make this dichotomous decision tree, which isn't helpful for the patient, and it's really not helpful for the diagnosis either. So there, you know, we do have some success with treating fibromyalgia. The important thing also is evaluating for anything else going on that could be worsening that. Opioids are not appropriate for fibromyalgia. In fact, they absolutely make it worse.
Wow.
Movement, just like with complex regional pain syndrome, which is, I really wouldn't wish that on anyone, by the way. It's a really painful one, but physical therapy, movement makes a big difference on improving from that. So that's one of the great things about, I had worked with a neurologist also, we were in the same building, who taught me a lot about fibromyalgia, and my partners are really excellent with that. Dr. Ken Wu and Dr. Yohan Malay, they are fantastic.
Awesome. Yes, they are.
Oh, cool. Thank you very much, Linda. I appreciate it. It was just a shout out.
Thanks.
And if
You
anyone
see-
has questions before we run out, hopefully my email was up long enough. Definitely feel free to shoot me an email. You know, I'm happy to help if someone's got a challenging patient or they don't know what to do or something. You can always shoot me an email. I'll do the best that I can. I never promise anything other than I will do the best that I can.
That's all we need.
Yeah.
Well, you
So-
did more than the best you could today. You did fantastic. Thank you. You have great energy. In fact, one of the ladies, I can't find her now, she said she loved your energy. So I agree. You made it fun, and that's not easy to take a topic like this and make it fun. So thanks for doing that.
Yeah, it's if you can't have fun, I mean, this is way, way, way too important to take seriously.
Yes.
I mean, if we can't laugh, and for me, that's also part of it's part of how I've always dealt with really tough situations, is I crack jokes. And
Me
that's
too.
just been a coping skill for myself.
Jamie too.
But really, again, I love doing this. And for the record, I never wanted to do this. Never wanted to do pain, never wanted to do addiction. This was not my plan.
Me neither. This picked me, and this picked you. That's
Absolutely.
how I tell people. I did
I'm
not
glad it
pick.
did.
Yeah, no, I'm clear. There's a lot of years I'm like, why didn't I die? Because a lot of people had died from a lot less than me, and I get it now. Like this is what I'm supposed to do. So here I am, doing it.
Keep doing it. Keep
Thank you
doing
very
it.
much.
Thanks so
you
much
so
again.
much.
Awesome.
Yeah.
Thank you
And
guys
we are
very, very
gonna-
much. Really appreciate it.
Yeah,
I'm
we are
gonna
going to
cut-
put this on YouTube and post it on our website. So if anybody else wants to watch it in the future, it'll be there. You're a YouTuber now. So
Oh
All
my God.
right.
My 10-year-old is gonna be like, Dad, check it out. Check it out.
It's embarrassing.
How many
Okay.
views do we need till we start making money?
Find out, Eric.
well,
All right.
great. Y'all have a great
Thanks,
Thanksgiving.
everybody.
Thanks for
Thanks,
joining
Eric.
us. Thank you.
Appreciate
Thanks,
it.
everyone. Have a
Uh-huh.
great day.
Bye.
Bye.